Hi, this is Brian Wormers recording a lecture for pediatric nursing over the topics of hematological and immunological dysfunction. So today we'll be talking about anemia, and particularly iron deficiency anemia. We'll talk about sickle cell disease, we'll talk about aplastic anemia, we'll talk about ITP and hemophilia, we'll also talk about leukemia and HIV. So just like all the lectures, always start with history. So ask them if they have any history of hematological or immunological disorders in them, in their parents, and anybody in their family. Other things that you might want to ask about would be activity level. Are they able to keep up with their peers? Are they short of breath? Are they tired all the time? Are they hot? Are they cold? All those things can be signs of hematological dysfunction. What's in their diet? And especially we can talk about like pica and stuff like that. Susceptibility to bleed, so we're talking about hemophiliac here, ITP. We talk about frequent infections, so even HIV, leukemia, or other things like that. And then bruising. So looking at your physical exam, you're looking for all those things as well. So bruising could be a big thing. Bleeding, different stages of bruising, looking for signs and symptoms of infection. You know, you can have all these type of things. Headache, kidney pain, bone pain. We'll talk about all this here in a little bit. So anemia is dealing with your RBCs and your red blood cells. Usually the normal indices for RBCs are, generally speaking, about 12 to 16. One of the easiest ways to think about anemia for me is either a decrease in red blood cell production, so you're not making enough, you're losing it, or your body is destroying it. And so as we go through this first section here, you're going to see that a lot of the signs and symptoms are going to be the same. They're going to be having decreased pallor, they're going to look pale, they're going to be tachycardic, they're going to have some headaches, they're going to be short of breath, they're going to be fatigued, they're going to have some weakness, and you're going to kind of see this all the way across because they just don't have the hemoglobin carrying the oxygen that their tissue needs. So pica is one of those things in here that's maybe a little bit different because they're trying to supplement maybe what they're not getting in their diet. So if they're iron deficiency, maybe they're eating some clay or different stuff like that, trying to get iron in their diet. You may also see that they have some heart murmurs related to this, because if you've got decreased RBCs, it changes the way that blood flows through your heart, and you can sometimes get that whooshing sound of a murmur. So with this, you're looking at decreased red blood cell production, and probably the biggest thing for this would be iron deficiency anemia. And so we talked about that earlier, about how when kids get to be about 1 year of age, they start transitioning into whole milk often, and then just some finger foods. If they're drinking way too much whole milk and they're not eating enough, eating any of that fortified finger foods, then they tend to get iron deficiency anemia. And they look pale, and they have decreased energy, and all those different things. But that nutritional deficiency is probably the most common cause of anemia in kids. We can see some of the rarer stuff, so folate, B12, copper. I have seen all those things, but by far and away, iron deficiency anemia is the most common. Bone marrow failure, so you can see this. So if they have a leukemia or something like that, where they're not making the cells, oftentimes this can be to chronic diseases where they're sick for a long period of time. It can be from ALL, so acute lymphoblastic leukemia. It can be from medications that we give. So long-term antibiotics can have a rare side effect of this, but more commonly it would be chemotherapy. So next one would be cell loss, so you're bleeding out. So you're going to have all those signs and symptoms. This is more of an acute type of situation. One of the top 10 reasons why kids have nosebleeds are their 10 fingers that are on their hands, because they pick their nose and then they get epistaxis, which is nosebleeds. Acute blood loss might also be hemophilia. One thing that you might see on some of these kids is that for males, when they're young, one of the procedures that they have done is a circumcision. And so if they've got prolonged bleeding, that might be the first indicator you have that your patient might have hemophilia. It can be hypersplenism. It's kind of rare, but if your spleen is knocking things out, that could do it. We'll talk about ITP. DIC we don't talk a lot. You'll talk about more of that in high acuity. DIC is disseminated intravascular coagulopathy. And so part of your blood is clotting while part of your blood is too thin. And so it is one of my least favorite things to treat because you're kind of stuck. Do you try and thin the blood to try and prevent blood clots, or do you try to, help the clotting out a little bit and then risk blood clots? And so you balance that out, and it's just not much fun. Last one here is increased cell destruction. So you're going to have all these things. You can have dark urine if you're getting a lot of waste products to the kidneys. Frontal bossing would be a long-term type of situation. And frontal bossing is just the front of their forehead gets big and pronounced. You might also see a lot of icteric sclera, so their sclera get yellow, and that's the waste product. So if you're thinking about being jaundiced or hyperbilirubinemia, it's kind of the same look. So what happens with the cell destruction? So, it could be like a sickle cell disease or a thalassemia. They're kind of rare, but we'll talk about sickle cell in a little bit. Enzyme deficiencies, G6PD, which is pretty rare, and spherocytosis, which is another pretty rare thing. Extracorpuscular, so outside of that, so some of the chemotherapies that we give will destroy those cells, radiation, infection. Sometimes it's, these things that we give to try and help treat other things can lead into complications and destroy those red blood cells. So looking at diagnosing anemia, we kind of talked about all this before. So the first part here is just remember your atraumatic care. Try to be nice to kids, especially if we are drawing a lot of blood. On little kids, we can actually draw out enough blood with different labs and stuff like that we can make them anemic. So that's why this is in here. Look at your policy and procedure for your institution that you're in for how much you can draw, because we don't want to make our patients anemic. So what do you look for? So that conjunctiva is pale. It's not really red and injected like it should be. You're looking for a pale pallor. This patient's pretty whited out a little bit and just decreasing pallor. You're going to maybe hear that some cardiac murmurs. You might see some cyanosis because they're not getting oxygen to that distal cells. They might have some weakness. So all those things can happen, so then we should treat them and then minimize their demands on energy. If they're worn out, most of the time they want to sit down and rest a little bit, but this might be one of those things where we encourage that. Iron deficiency anemia, we talked about that previously, and it's just good for you to rehear this information. But one of the most prevalent things in the United States at this time frame here, 1 to 3 years, because of switching to whole milk. Preterm infants are especially at risk because that last trimester is when they're supposed to get the iron, but if they are born earlier than that, they don't have the fetal iron supply, so then they're kind of behind the 8 ball, so to speak, and they have a hard time catching up sometimes. So adolescents, and I even think college students sometimes are at risk because they don't always have great eating habits. Sometimes they make some choices that maybe aren't the best for eating. Sickle cell anemia. So sickle cell anemia is a hereditary disorder in which you are changing the shape of the cells. And so if you're looking here, this is nice and round, and this is what it should look, kind of a donut with a kind of a clearing in the middle. You're seeing a lot of sickle cells on this slide. So here's one, there's one. So for me, the best way that I've described this is, if you think about floating down a lazy river at like a water park, and you're bouncing around in your nice round inner tube, and things kind of go smoothly. Now, if you were to replace that with these cells that are more like kayaks, you can imagine how that would really kind of jumble up the work sometimes. And so this isn't necessarily a clotting issue, so heparin doesn't necessarily help with this, but it's just how it gets wedged in that vascular space. So you can imagine that this might fit, but look at how wide this is comparatively. So notice that sickling can cause some complications, and we'll talk about that here more in details. This is an autosomal recessive, so both parents have to have the trait, and your whole Mendelian genetics with this. African Americans are only about 8%, while 40% of Native Africans are carriers of this. So there's a big discrepancy here. One theory for why sickle cell anemia exists is that malaria really doesn't like it when these cells are sickled. And so it might be an opportunistic or a compensatory situation by that person's body to try and protect themselves. At least that's a theory of it anyways. So we talked about replacing this normal hemoglobin with abnormal hemoglobin S for the sickle. And so it takes that sickle shape. So sickle, think about those old farm implements that they used to cut. That's a sickle. That's where you get this name from. But they're long, they're rigid, and they obstruct that blood flow. So if you think about diabetes and you get microvascular things, it's all the same stuff. So specifically looking at your eyes, so you could get some retinopathy from that. You can get like stroke-like symptoms in CVA. It can definitely affect your kidneys. It can affect your small blood vessels. It's going to talk about hematuria, so like I said, your kidneys. One kind of weird thing that's listed on here is priapism. Priapism it happens in guys, and it's an erection. So basically you're getting blood in, but you can't get blood out. So these patients can go into crises, and so what can happen in a crisis? We talked about all that stuff on the other slide, but you can also lose your spleen. So after a period of time, these patients that have got sickle cell that have gone into a couple of different crises will often stop perfusing to their spleen, and realize that they'll lose that then, and that's part of their immunological system. So we do have to watch that. Ways to help them out, of course, try and make sure that they don't go into this crises, and then try and make sure that they get their immunizations and they're up to date on this. So these vaso-occlusive crises hurt. I mean, you're getting hypoxic from this. The tissue is getting ischemic and dying, and so it really, really hurts. And so we really try and do our best to correct that quickly. So, risk for strokes, clog up the small vascular system. So they can also get ACS, and so you get these pulmonary changes here. And so it's like pneumonia but worse, and it's pulmonary infiltrates. So what are some of our priorities with this? So, of course, prevent sickling whenever possible. So some of the main things that can lead into sickling is dehydration, stress, and hypoxia. So then, of course, we're looking at promoting rest, trying to take off the stress of this one, giving oxygen. We're going to hydrate really, really well and trying to prevent that sickling. It also fills that vasculature. So it's that lazy river once again. So if you're kind of just doing a trickle through that lazy river, you're not going to have as much success as if it is really wide and full and you got lots of fluids running through there. Pain control, so this really hurts. Oftentimes we'll give morphine for this. Number one, because of pain control, but number two, it's the same reason why we do it for adults with cardiac, like heart attacks and strokes and stuff, because they're trying to use that side effect of the vasodilatation to try and open up the vasculature. And so sometimes that can clear those clots a little bit, or not clots, but the blockages. Monitor labs. If they're stressed out because of an infection, they only treat with the infection. Immunize and try to prevent them from getting sick and stressed. And then in rare cases, we can do meds such as hydroxyurea, but not usually. It's a tool, but it's not commonly used. So, as for story time, I once had a little patient that was, she had sickle cell disease, and she also had a leukemia, and so she was en route from Denver, Colorado, down to Disney in Florida for a Make-A-Wish. On the flight, though, she went to a sickle cell crisis, unfortunately, and then had to be hospitalized. So the plane landed in Sioux Falls, diverted there, and we got to care for her. So, just like we did here. So we pushed fluids, gave lots of fluids, gave some morphine for pain control as well as for opening up that vasculature, put her on some oxygen, and surprisingly enough, overnight she did much, much better, and she was able to go the next day. But if you think about why she went into that state was, well, it was probably eustress. So she was excited to go to Disney. And so eustress we don't often think about as having complications, but with her, that could have been the reason for it. She was also flying at altitude, so altitude can change hypoxia and different stuff like that. Also going through the airports can lead into things such as like dehydration, because water is really expensive. You don't always have access to it. I know that there's drinking fountains, and now TSA is pretty good about letting you take an empty water bottle, but there are some barriers to drinking appropriately. So once we got her here, like I said, she was in our facility for one night, and we were able to correct it, and then she was able to go back to Disney World. Alright, so bone marrow failure. So this can be lots of different things. We talked about anemia with RBC production. But if we're looking at bone marrow failure, that's all cell lines. So really think about what that's all going to do. So if we're aplastic anemia, then that's impacting your RBCs, your WBCs, and your platelets. And so what are your signs and symptoms related to these three things? And you'll have to know that for your test coming up. So for your decreased RBCs, we talked about all those signs and symptoms of anemia before. For the next one, for decreased WBCs, that's definitely an immunological type of situation in which they can't protect themselves. They're getting infections all the time, possibly recurrent infections, possibly getting very, very sick with those infections. Platelets, we're going to have decreased clotting ability, and with that, we're going to have more bruising and bleeding. And so, oftentimes these patients will come in and they've got multiple different bruises all across their body, more prone to bleeding around the gums, more prone to bleeding out through the nose and nosebleeds. And so as you're comparing all these things, now you got to take care of the patient that's got all these. And so you've got to protect them from infection, you got to treat the anemia and work with that, and then you've got to make sure that they don't bleed out too much. So this tool is good, but make sure that you can appropriately utilize that on a test of, what are your signs and symptoms for each one of those, and what are some of the things that you would do to intervene. So things we can do, immunosuppressant therapy with this, so sometimes steroids, sometimes IVIG, or, a bone marrow transplant. So leukemia, so ALL is probably the most common in kids. If you're going to get leukemia, if you're going to get ALL, you want it as a kid. Remission occurs in 98% with long-term survival of 90%. And if you get this as an adult, your outcomes are not as good. So knowing that we can successfully, have long-term survival rates of 90% is pretty good. We're still trying to eliminate this entirely, but these aren't such bad statistics, unless, of course, you're the 10%. Pathophysiology, so what happens? We don't really know why this happens, but what happens is that you get WBCs that just make themselves on too much of a rate. So your body focuses on making WBCs, fails to make the other cells, and when it does make the white blood cells, it often kicks them out immature. And so even though you've got lots of white blood cells, they're often not functional. What I've seen is usually it's pretty, when you do labs, it's pretty obvious, because, if you get your WBC, that's normally 10 to 15 or so. For some of those leukemics, I've seen them above 100,000. And so it is marked once you do the laboratory and the serology, usually. So liver and spleen are affected because they're highly vascular, as is lungs and kidneys. So all these kind of fun things that you can read through. Bone marrow suppression is one of those things that we've got to be careful with. These kids will often come in and they're going to present with bruising, very commonly, also bone pain. So because it pushes on, as they're trying to make all these white blood cells, it pushes on that bone marrow. And so they often have a lot of complaints of discomfort within their legs. So those are some of your big things. If you're worried about it, you'll do a CBC. If you're suspecting it, then of course you'll check a smear to look at those different cell lines and see how they're progressing along and where they're at. And then, of course, you'll do lumbar puncture to see if CNS is involved, and then you'll do bone marrow biopsy just to see what that bone marrow is producing. So treatment, it's often chemotherapy. So we got to be careful with that with chemo. Sometimes doing cranial radiation, sometimes doing intrathecal kind of chemotherapy. We do have to be kind of careful. It's one of the biggest ironies, I think, in medicine is that chemotherapy and cranial irradiation can cause cancer, and so we have to be very careful with that one. Also, chemotherapy can be very dangerous. We've got to be very careful when we give it. We don't want that to, we never give it through peripherals or anything like that. If you're giving it, you really should have additional training on this, because you don't want to be exposed to it. You don't want it to leak out on your patient. There's specific ways on you back priming it and getting it ready, and the equipment that you have to wear to do this. Oftentimes we don't have our nurses that are pregnant or trying to get pregnant give chemotherapy because it can impact the fetus. So really we take some high precautions with chemotherapy, and you've probably seen some of that on your med-surg rotation. We can give stem cell transplants, and that can be very effective in 60 to 70% of patients. Oftentimes before we do that, we do give chemotherapy to wipe out those counts. But in doing so, there's significant risk of morbidity and mortality because we're dropping all the cell lines. So their WBC count will bring them down to an absolute neutrophil count of 0 often. And so that puts them at significant risk for infection. When we give these, of course, there's risk for graft versus host disease where their body doesn't take the bone marrow transplant and fights it, or the bone marrow transplant fights the body. They can get a big nasty infection from this. And so there are definitely consequences for this and things that we have to be careful of. So caring for that patient with leukemia, so yeah, we're doing all those different diagnostic procedures. Of course, we want to prepare the kid and the family for what's going on. We want to be careful and treat pain. Pain is one of those things that we just don't like to see if we can avoid it. And so, like I said, bone pain is a really big thing. With these kids, if they're in pain, we're treating it pretty aggressively. So we talked about bone marrow suppression from chemotherapy agents and stuff like that. So really trying to be careful with them. Infection control is a must. And this can be really tough, especially if we're trying to keep their siblings away from them or grandparents that are sick away from them. And so sometimes we'll put them in reverse isolation, trying to protect themselves from all the other bugs that are in the hospital. We talked about chemotherapy and how to protect ourselves from that. Drug toxicity, so when we're given that chemotherapy, often we've got to use lots of fluids trying to keep those kidneys and the bladder hydrated well and fluid running through there, not so that you get the waste products sitting and pooling in the bladder or going through the kidneys and damaging the kidneys. Zofran and other antiemetics are huge. When we talk about chemotherapy, we give it on a schedule based on what type of cancer that they have and what type those cells reproduce, because we're trying to get a max efficiency out of this. And so it's very regimented about what time you are giving the meds. And notice that we'll probably be giving Zofran right before we give the chemotherapy, because it is so much easier to stay ahead of nausea and vomiting than trying to catch up once it already starts happening. So anorexia is a big thing with these patients. They don't feel good. They don't want to eat. Sometimes the chemotherapy makes them nauseous to smells and different things like that. So think about those different ways we can get them to eat and drink. Have those little med cups, having tea parties, having sticker charts. Make sure it's the stuff that they want. I'm usually a little bit more lenient for what I feed them if they're willing to eat some. We also have to be careful with the types of food that we have. So if they're immunodeficient, we sometimes don't let them have a lot of fresh fruits and vegetables because there can be bacteria on that and that can make them sick. While chemotherapy is great for killing those cells, it also kills the cells of some other body parts, so GI tract, mouth, and so we got to work with mucosal irritation. We have to worry about the bladder and hemorrhagic cystitis. And so, like I said, we're really trying to flush things out. We're really trying to protect this as well. For mucosal irritation, often we'll give something called magic mouthwash, and that is things like Benadryl, lidocaine, Carafate. So every hospital's got its own little different recipes for this. But what you're trying to do is coat that mouth and then numb things up a little bit so it doesn't bother them so bad. Hair loss is a big thing that we think about with chemotherapy. Some of the newer drugs are better about not causing this, but if we're giving drugs that will, we have to let them be aware of this one. So think about it also, it's not just the hair on the top of your head, it's eyelashes and eyebrows. A friend of mine that lost her hair due to chemotherapy treatment said the worst thing was that she'd always get sweat in her eyes because she didn't have eyebrows and eyelashes. And she's like, that it just kind of hurt. And it was just annoying. So, also when the hair grows back, it doesn't necessarily grow back the same way. So if they were blonde hair and straight hair, they might come back with dark brown and curly. And so it's kind of interesting how that happens, but also prep them for that, and that their hair that they had might not be the same type of hair that will grow after treatment. Talked about chemotherapy. It's a vesicant. It's there to destroy cells. So if it goes in the wrong spot, it's going to cause huge, nasty issues and destruction of tissue. So we only give it through peripheral, or we only give it through central lines after we're checking for patencies. We never give it through peripheral. If you have any question about if it's a good line, you're stopping it immediately. Last little thing here is, as we're giving chemotherapy, it can impact sperm and eggs, and so we might, see if they want to donate prior to treatments, because fertility might be impacted later on in life. So other types of anemias and red blood cell loss. So hemophilia. Hemophilia is a hereditary type of situation. More guys are affected because this is an X-linked recessive disorder. Hemophilia A is probably the most common with 80% of cases, and that's caused by a factor VIII deficiency, and that's classic hemophilia. One big thing that I hear with some nursing students and stuff like that is when we talk about hemophilia, it's not like it comes out with a lot of force, and they're not spraying blood all over the place. It's just a delay in clotting time. And so they bleed just like everybody else, but they have a hard time clotting, and so they bleed a longer period of time. So we can also talk about von Willebrand disease. So that's factor VIII. That's how this is tied together, but you know that can affect boys and girls. Think about all those different things within that clotting cascade. And so if one thing is abnormal, then that can cause us to have bleeding disorders. So they bleed longer, not faster. We talked about that. You know, symptoms might not appear till a little bit older, but remember with little boys that circumcision is one of their first treatments or one of their first surgeries, and that might be the first sign and symptom that somebody's got hemophilia. I have seen a little kid that had a circumcision and they couldn't stop the bleeding afterwards, and then it led into that child actually dying because of it. This child, you know, bled into his diaper overnight, didn't get caught till the next day, and then when the child came to us, hemoglobin was at about a 3, and we couldn't get back, especially because it was an acute blood loss situation. So you'll see that some of those patients that have got chronic blood loss, they can handle those changes. They can get down to like a 6, and they're acting pretty normal. But when it's an acute situation, it tends to hit them a little bit harder. And so just be aware of that one. So that's that surgical situation. ITP, so we're not really sure what causes ITP. The theory is that oftentimes there's like a respiratory infection that happens, and so the theory is that you get antigens from that respiratory that seed on some of the platelets, and then your body thinks that the platelets are you know, infections because they've got the antigens on it, and so your body will destroy those platelets. So with that, it's an autoimmune disorder in that fact. So, you know, normally our platelets are 150,000 to like 350,000 or 400,000. On some of these patients, they could be like 10,000. So it's a very significant change. So how do they present? Well, they're lacking their platelets, so they're going to have bleeding things. They're going to have more common nosebleeds, bleeding around their gums, bruises, all those different things that we talked about earlier. Treatment modality can be steroids, but often is not. The reason why we don't use steroids is because if this is a leukemia or something else a little bit, you know, stranger, then we can alternate or alter the pathway that they have to be on for their immunization or for their treatment then of that cancer. And so prednisone is probably not one of our big ones. We can use it, but it's not common. More common is IVIG, and so with this one, we got to make sure that it's got a kind of a set thing like blood. So we will slowly ramp it up. Every hospital is going to have a protocol about how you give it, how fast you can give it, when you can titrate it up, what are your procedures beforehand. Of course, we're doing frequent vital signs and assessments. Anti-D antibody or Winro is what we give the moms that have got a different blood type than their fetus, and so this will sometimes calm that body down as well. So if they've got ITP and we're thinking that it's the spleen that's, you know, destroying all the platelets, sometimes we'll remove the spleen too. So HIV, I'm not going to ask you to know a lot about this, but realize that it is on your CD4 cells, which are white blood cells. And so having abnormal white blood cells is going to lead into a host of immunological problems. And so that's the big thing with this one. Clinical manifestations is often they present with infections and possibly recurrent infections like recurrent UTIs. It's probably one of the bigger ones. As this progresses, you might see different rashes and Koplik spots and those kind of different situations, but that's usually not your initial presentation. Initially, it might be more along the lines of like flu-like symptoms. So, I mean, how many of you have had a little fever and flu-like symptoms and not rushed out and thought it was HIV? And that could be part of the complicating factors of this, is that when it's early on in the prognosis and early on, you might miss it. Therapeutic management is usually a cocktail of drugs. I'm not going to ask you that you know what drugs are involved with this because it changes. But realize that it's usually multiple different drugs, often on weird time patterns. It's usually expensive. Although we are starting to get better about our meds, and there's new meds coming out. There are combination meds with less frequent dosing. And so we are getting better about some of those meds. Nursing care management. So we have to protect their privacy. There's still a lot of stigma about HIV and AIDS. And so that's part of the big care management is protecting their privacy and protecting them, as well as, you know, all those other clinical manifestations and trying to protect them and, you know, watching out for their immunological status. There have been a few people that have put this in remission and have been free from this. Some of the meds out there are getting really pretty good and bringing them down to undetectable levels. So that's pretty cool when they're on the medications. So we are getting better with our treatment modalities of this. Last one, review blood transfusion. So make sure that you're able to do hang blood, know the routines for this one. You know, O positive is your, or O negative is your universal donor, AB positive is your universal recipient. You know, so know what blood types can go with which type of situations. Often, you know, O neg is what we take on flights or emergency situations because it's usually safer. There's still always risk when you give blood products. There are some new, I mean, the O, A, B, AB, and then your rhesus of positive or negative for your antigens is kind of a classic way to do this. There are other ways, and they're starting to come out with new typing and screening to be more specific on this. I just read something yesterday about they're coming out with a new blood type, and and although it's kind of rare, they're starting to push it. And so you might hear of one called ER. So just realize in your lifetime that might kind of change and deviate from that, you know, classic way that we do things. When you're hanging blood, you know, go through all those steps. You know, you need the doctor's order. Know what a type and cross is. Looking at that blood, mixing it with the patient's blood and seeing if it goes to war, so to speak. And so that's probably the best indicator that you won't have a reaction. We can do type and screen and looking at, you know, what type of blood we should be giving them, looking for any infections and stuff like that. When you're giving blood, remember it's 2 nurses. You're double checking everything. It's got to be the right patient, the right time. Make sure it's not outdated. Make sure it's not cloudy. Make sure it looks good. Make sure you got the right documentation. Make sure you're checking blood bands on patients. When you string it, you're stringing it with normal saline. If you hang it with hyper or hypoosmolar fluids, you'll lyse those cells. And so number one, it's not good for the patient because they want those whole blood cells. But then if you're lysing all of them, then you're getting the increased bump of potassium, which can cause cardiac arrhythmias and kidney failure, as well as you get all those cellular debris in there, and that can jam up the kidneys as well. So we want to make sure that we're not lysing those cells. Checking vital signs very frequently. Every place has got its own policy and procedure. I'm kind of used to, you know, baseline vital signs, and then, you know, Q15 for 1 hour, half hour for 1 hour, and then hourly until you complete. You can push blood, but you've got higher risks of side effects with that. But in an emergency and in trauma, of course, we can push it. Usually, though, we give it over 2 to 4 hours and try and let it run in because there's less side effects of that and less risk for even fluid overload with that. So with that, if the patient starts getting a fever, feeling nauseous, getting kidney pain because with that potassium and the cellular debris, those kidneys can jam up, and so kidney pain is a big red flag. They might get rashes. Any of those things they should report to you right away. I often just told my patients, if anything feels weird or wrong, let me know. And I'd rather, just know about it and have it be nothing than, find out too late that it was something we should have intervened with. So, and then of course you're checking on that, making sure it's having therapeutic responses and stuff like that eventually. So, all right, well that concludes this lecture on hematological and immunological dysfunction in pediatric nursing. If you have questions on this, please contact me.